hard of hearing or deafness is something that more likely occurs to individuals over the age of 50. And as you can see in this graph, that there is a percentage of individuals, it just primarily focuses on individuals over the age of 50. You can see that 1 in 10 in the decade of the 50s, 1 in 4 in the 60s, half of the population in the 70s, and 8 in 10 in the 8th decade have some sort of hearing impairment. And over the age of 12, the percentage is 14.3%. And so the incidence of, or the likelihood of you working with individuals that have some level of hearing impairment, especially if you work with adults, is going to be much greater, especially as they get older. You'll also notice that primarily the impairment is relatively mild, which is indicated by the teal color bar. Moderate is orange, and that as a person ages, they're more likely to have more severe level of hearing impairment. Being hard of hearing means that someone is able to have an improvement with a hearing aid, and they just might have difficulty understanding speech. Deaf is when somebody has a profound level of hearing loss and may need to have additional ways of communicating. The thresholds on the bottom of the slide just indicate how the progression of when a person can hear a sound. There's a threshold of decibels that severe is 60 to 90, which really won't mean much to you at this point in time, but there is a little video in the that I've set aside for you to get an idea about what that sounds like. Why we need to be concerned about someone having severe hearing loss is, well, they're more likely to be obese, they're more likely to be inactive, they tend to be less likely to have self-confidence. Many times people will just not participate in things because they can't hear very well and have some difficulty with being able to communicate. You will notice that individuals or kids, when they have hearing impairment, when they're quite young, they might also have speech impediments that go along with it. The symptoms of hearing impairment are pretty varied. You might notice somebody that says, huh, what'd you say? Can you say that again? What'd you say? And individuals will ask for people to repeat. They'll accuse individuals of mumbling. You're just always talking like you're not talking very loud. Can you turn up the TV? When I was young, my dad had to have the TV on really loud, and it was one of those things that I just kind of grew up with. Also, sometimes difficulty on the phone, and I noticed that I have differences in my ears, that I tend to use the phone on, goodness sakes, my right ear. Hold on. Nope, my left ear. I usually listen to my left ear than my right ear because it's a little bit better, but people that have more severe hearing impairment are going to have difficulty having phone conversations, and sometimes they won't even talk on the phone. 3 primary types: the conductive, sensorineural, or mixed. And the conductive involves the outer or middle ear. The sensorineural involves the what's basically more middle. It's aging, exposure to loud noises. It could be from a disease or it could be inherited. And mixed is when somebody has a combination of those two. Mixed hearing loss tends to happen in senior citizens. Conductive hearing loss occurs when sound cannot pass from the external and middle ear to the internal ear, to the cochlea. And this can be due to some sort of a blockage or birth defect, ear infections, cold, sinus, allergies. This is when somebody might need to have tubes put in their ears. They have blocked eustachian tubes. The The most common type of hearing loss is involving the cochlea or the inner ear, and there's a wide variety of potential causes of this sensorineural, and most of the time, about 60% of the time, no one knows why it happens. It's not from meningitis or trauma or measles or scarlet fever or rubella. It is unknown. Now you'll notice that this is exposure to excessive noise is a pretty common one, probably in individuals of my generation. And also aging, as I showed you, that increase in hearing impairment is much, starts around 50, 60, 70, and then arches way up and is real high in 80s. And so that's most, would be like a big sensorineural involvement. Here's the inner ear with the semicircle ducts. We've got those small hairs that are involved in there. The cochlea, which that's where the hairs are, and everything is based upon moving of those hairs. As we get older, we get fewer and fewer of those hairs, and so we don't hear quite as well. The nerve, the vestibulocochlear nerve, can have damage. That could be one of the causes of hearing impairment. Here's your middle ear, which has your malleus, incus, and stapes, your eardrum, and that is that component. Mixed is the third type. That is a combination of the two primary types. This occurs more likely in the older, in senescence or in aging, and you can have that cause of the conductive, you can have some sensorineural involvement, and then you have mixed, can involve the combination of both of those, and also have some genetic infectious or head trauma cause. For hearing impairment, the challenge is going to get someone to use a hearing aid. If you speak to someone about hearing aids, they'll often say that it's frustrating. They're more, if they don't have an effective one or it doesn't fit them well, it might amplify all the sound and it just sounds like loud noise instead of being able to pick up voices. So hearing aids are somewhat challenging. Now there's some new involvement in getting some smaller hearing aids and making them more accessible for individuals. Many individuals don't need to have that they have hearing loss, and they could probably use a more generic hearing aid. And I know that that's part of what's being discussed to make the access to hearing aids more available for individuals and have it paid for by the health insurance, because man, I'm telling you, they can be up to thousands of dollars. You can have several locations where they're located behind the ear, in the canal, or completely in the canal, and those completely in the canal are the little itty bitty tiny ones that fit right in there. So you can imagine you have to have a really good fit to have that hearing aid fit in there and not fall out. Also note that there are going to be instances when that hearing aid needs to be removed during exercise. So for instance, you can't wear your hearing aids when you're swimming. So here's the range of what these hearing aids are going to look like. You can imagine that there is a likelihood of losing the small ones and having the larger ones be broken. So, and also there's a potential stigma, and people might not want to wear those larger ones. The cochlear implant is a potential option for individuals that have profound hearing loss or individuals that have significant hearing loss. And you have a discussion about individuals that might not want to get a cochlear implant and that they feel that they can communicate just fine without having that assistance. So that is kind of a debate for individuals that have not been able to hear for their lifetime, and then to get a cochlear implant, it's very difficult to get adapted to it, and they might not want it. So what does exercise do for individuals that have hearing impairment? Well, it does not have an impact on their exercise response. In other words, their cardiovascular, cardiopulmonary response. You should not have any anticipation of having abnormal exercise response. However, it does give individuals opportunities to be involved, to have interaction with individuals, to build that self-confidence image, to improve spatial orientation, and it can really be effective for kids with hyperactivity and help with their anxiety. So exercise has a real positive role for individuals that have hearing impairment. If you do exercise testing, it's primarily for the two major reasons: is there cardiovascular disease, and exercise programming. There really is no specific medication that is going to be prescribed for individuals with hearing impairment. However, you do need to be aware of other medications that a person might be on. And so I'm going to remind you to take a look at Table A in your guidelines book. Now, this is the picture from the 10th edition. I can't seem to get a good picture from the 11th edition, but it's the same thing. It's just a different color. And you'll see that the very first column has a classification of medication. It then goes to what does that medication, how does it influence the cardiac output? Does it have an impact on the third column, which is heart rate? Does it change or alter blood pressure? Would you expect to see any EKG changes? And what impact does that have on exercise capacity? Now, why this is important to understand is that when you're doing an exercise test and someone is on, say, example, a beta blocker, you need to really understand that their heart rate response is going to be blunted. Their blood pressure response is going to be blunted. Their exercise capacity is initially going to be lower, but then as they get acclimated, then they're going to have better, they'll get accustomed to it, and they'll have better exercise capacity. Now, what a beta blocker is given for is for either oxygen demand, to decrease the oxygen demand of the heart, and one way of doing that is to decrease blood pressure. Another way is to decrease heart rate. And so somebody with hypertension is on a beta blocker, and you will want to know that because their heart rate response is going to be lower than expected. And as I mentioned, people that have hearing impairment, they're going to be often over 50. If you're over 50, you're more likely to be on medications. So know the medications that are going to go along with your patient or your client. With exercise testing, there are some potential spatial awareness difficulties with a person that has hearing, that is deaf. And so you want to be aware of that in the sense that maybe safety with a bicycle, being on a bicycle, if somebody's a little tippy or trip easily, that's always a good rule of thumb. If somebody doesn't hear well, you might consider having them watch a video before they come and do their exercise test, or watch a video while they're there. You can demonstrate how to get on, how to get off the exercise equipment. You can write down a brief description of what you're going to do. And exercise testing is going to be important, especially for your older client. And so understanding your client's preference is going to be important as well. But think about it in terms of what you would normally explain verbally, you might have to explain visually and not go into a lot of narrative. So for special considerations, we're thinking about having very clear instructions, have something that somebody might want to jot, a little notepad that they could jot down. And this is something that is true all the time, but especially when somebody has hearing impairment. Look at them when you talk, make eye contact, nod, and you can use visual and tactile cues. In other words, if you need to say step over here, maybe point, and while you're speaking, that's helpful. And thou shalt never chew gum when you're working with people. That's the 11th commandment. You want to be very conscientious of your facial expressions and your body language, and pay attention to the other person, to your client's facial expressions and body language. Do not yell. Just speaking louder does not help. If you want to speak in a normal volume, and especially if somebody has a hearing aid, you can communicate with them and ask them if you're speaking, if your speech is loud enough or if it's too loud. Don't pretend. Never pretend to understand. Either ask for clarity, ask them to write it down. Never pretend. Avoid a noisy background, because especially if they have hearing aids, everything potentially could be amplified and they won't be able to discern you from the noise. Visual noise is a lot of visual distractions. You don't want to have a lot of visual distractions, and know when it's important to remove those aids, hearing aids, before they start to exercise. If you have an opportunity, if somebody is it does have spatial or balance issues, we want to be very conscientious of that, give them feedback, start a little bit lower intensity, and be very mindful of working to improve balance and core strength, for example. So the take-home message is: use video if possible, if needed, depending on you can have a video of the test right there. There's so many now, it's wonderful. Be mindful when that aid is in and how to speak. Use visual whenever you can. Look at a person. When somebody is exercising, I forgot to mention this, that's why it's good to have this note. Thumb up, thumb down. Have signs, hand gestures. So if you're giving an exercise test, whether somebody's hearing impaired or not, you always, and if you're doing a cardiopulmonary, you'll say thumb up, thumb down, or a shake, hand shake. You want to have clear start, stop gestures. Don't pretend. And spit out that gum. And that is it.